Hemal, is presentation is
Yes, your screen is visible
properly?
Yes,
And
perfect.
I'm audible?
Yeah, perfect.
Okay. Thank you. Thanks a lot, Hemal, Ansh,
Thank you, ma'am.
Dr. Chakshu Chowdhury. Her continuous effort to make this session very fruitful. She is continuously interacting with me last 3 days. So hope to give a better presentation. Now welcome to the genetic world of neurodevelopmental disorder. By profession, I am a genetic counselor, and my PhD research was all around ADHD, this neuropsychiatric disorder, and my publications and everything. Then I have worked on Parkinson's disease in my postdoc experience and all. And now I'm working as a genetic counselor. So welcome to the genetic world of neurodevelopmental disorder. And thank you, Rective Genetics, for giving me this opportunity.
Thank you so much.
Dr. Ravi gave a wonderful talk on clinical aspects of ASD, its management, and everything. It was really, really a wonderful talk. And the first, what's the neurodevelopmental disorder? Now on, I think all of you must have understood that about what a neurodevelopmental disorder in fact is. And it is the most prevalent chronic medical condition that we encountered in a pediatric primary care center. Neurodevelopmental disorder is actually disabilities in the brain function which affects a child's behavior, memory, his ability to communicate. Maybe sometimes some movement problems are also there. Okay, Hemal, can we move the panel to the upper side or lower side of the screen? Actually, I'm not being able to see my slides properly.
Ma'am, what is the issue?
I'm not being able to see my slides.
I think our videos are showing on the top.
Yeah. Ansh, are you there in the meeting?
Yeah. So, ma'am, just shift from Zoom to your presentation. We will still be able to see your presentation, and you will be also able to see your presentation. Then just switch to the app, the PowerPoint presentation on your desktop, not the Zoom thing.
Okay.
Does that work for you?
Try changing your slide, ma'am. Yeah, it's moving. It's perfect.
Yeah, we are able to see your screen now. Yes, ma'am.
Okay.
Yeah, perfect.
Thanks a lot for your assistance.
No
worries, ma'am.
Please, we are ready to help.
So, in the common neurodevelopmental disorders, the few of them are mental retardation, dyslexia, ADHD, learning deficits, global developmental delay, and ASD, autism spectrum disorder. And the most difficult thing of diagnosis about the perfect neurodevelopmental disorder are two things. One is its multifactorial disease origin, and another is its comorbidities. So first, I'm coming to the multifactorial disease origin. What is this? What is this multifactorial disease origin? It is nothing. Whenever a single gene is a defect in a single gene is causing a disorder, then it's a single gene disorder. When different genes interacting among each other is causing a disorder or disease, then we call it as a polygenic disorder. And when different gene, that is the polygenic mode, different gene as well as the environment is interacting, gene environment interaction, that is mainly the causative factors of these neurodevelopmental disorders. Like you have heard about the torch test during the pregnancy. In our country, such a tropical space, most of the women during their pregnancy, they are getting this infection, cytomegalovirus infection, rubella infection. These infections are a major cause. These are environmental factors, and these are major cause of various neurodevelopmental disorders. And you know about different genes like Fragile X, and I will come later part of my lecture. Genetic susceptibility, MECP2 is there, for Rett syndrome, SANK1, 2, 3 are there. there are different genes of serotonin system, dopamine system, norepinephrine system, UBE3A for Angelman syndrome, and all these genes, along with the interaction with environment, when they are functioning as a causative factor, then the mode of origin of the disease is we call as multifactorial. Gene and gene environment interaction that is causing most of the neurodevelopmental disorder. First thing, and another thing I was talking about is the comorbidity. Comorbidity, Dr. Ravi also said that the overlapping phenotype, co-occurrence of the developmental psychiatric and movement problems like ADHD, bipolar disorder, depression, Tourette syndrome, schizophrenia, ASD, few symptoms are overlapping with each other. And these make the proper diagnosis a little bit difficult if the diagnosis is if we only rely on the express phenotypes. Actually, we don't see the patient for a long time. Mainly, we need to rely on their parents and other people, their reporting, and the time being for which we, in our clinic, we see a patient, they express phenotypes, and based on that, we do the diagnosis. But the overlapping phenotypes sometimes create some problems. So currently, though the psychiatric diseases are classified by the collection of symptoms together with observed clinical phenotypes as outlined in Diagnostic and Statistical Manual of Mental Disorder that we call as DSM, and presently it is using DSM-5. And it is more difficult if we see that rare neurodevelopmental disorder. Now you must have heard about that rare diseases, and every time we are calling that care for rare, and rare are many. This neurodevelopmental disorder, which actually that condition which affects fewer than 2 lakh people worldwide, we call it as rare. But investigating the genetic causes of the common neurodevelopmental disorder is sometimes finding that there are many more rare neurodevelopmental disorder existing in our society. But as we don't know the proper reason of it, so actually we don't know. Suppose there are 100 rare disorders are there. Actually, in the database, there are 7,000 rare disorders are there. In neurodevelopmental disorders, few problems we are generalized by their expressed phenotypes, and we are either grouping them with the learning disabilities, or with the developmental delay, or with ASD or ADHD. But if we investigate the proper genetic reason behind it, then we can only reach to the proper reason and cause of it. Now here, I like to say few facts to the journey of a diagnosis. From different reports, we have found that a patient with rare disease takes around 7 years, 7 years, yes, 7 years to arrive at confirmed diagnosis. And within these long 7 years, there are about 4 to 5 misdiagnoses along, and along with that misdiagnosis, different treatment, and maybe sometimes these effects of these treatments are not goes well with the patient. So to find the exact cause, exact reason is very important for a neurodevelopmental disorder. Now, here I have just listed few common phenotypes, clinical phenotypes, which we observe in neurodevelopmental disorder: weak muscle tone, hypotonia, mild to severe intellectual disability, delayed development, expressive language deficit in expressive language skill, vocabulary and the production of speech were particularly affected, then diagnosis based on these characters diagnosis. You may say it's a fragile X, FMRP protein is defective, fragile X. You may say no, if the seizure is present, along with that, it may be epilepsy, it may be Down syndrome, it may be Angelman syndrome, many things based on these phenotypes only. But With these phenotypes, working with that, genetic investigation found that it is a problem in 80 hook DNA binding motif containing one AHDC1 gene, and described as Zia-Gibbs syndrome. It's a rare genetic condition caused when the AHDC1 gene is mutated or missing. Usually, these problems mainly happen when we don't find any history in the family. That someone in that family before was not affected with that kind of neurodevelopmental disorder. So we call it as a de novo, happens spontaneously early in embryonic development. It may happen to that proband only, don't have a history of that kind of disorder. And in these de novo kind of cases, most of the time we found that genetic problems are underlying. So now I am coming to the point that why do we need genetic diagnosis at all in neurodevelopmental disorder? In terms of genetics, there are different types of problems: chromosomal rearrangement, copy number variation, deletion, duplication, small insertion deletion, point mutation. And these, to identify all these, there may be a chromosomal rearrangement that we can identify by karyotyping. There may be a copy number variation that we call as CNVs, insertion deletion. CNVs we identify by chromosomal microarray, insertion deletion, point mutation. These we can identify by different things. Insertion deletion here in India, we identify this by MLPA. Point mutation, different variation at a time, we can identify by next generation sequencing, that I will come later on in my talk. Then the first point, why do we need genetic diagnosis at all? Genetic diagnosis help us to identify the appropriate descriptive diagnosis. And it also clarify the recurrence risk. The mode of inheritance, it can tell us the mode of inheritance, whether the disease is autosomal, disease is X-linked, Y-linked. Mode of inheritance is what? That is, if it is autosomal dominant, then the mode of inheritance is autosomal dominant. Then in the next child, whether the couple can go for their next child or not. If they can go at all, then what will be the risk? If autosomal dominant, the risk of having affected child is 50%. If it is not autosomal recessive, if it is, then it is 25%. And now in the era of art, that is the artificial reproductive assistance is there. There we can opt for pre-implantation genetic testing, pre-implantation genetic diagnosis. So we can have a disease-free embryo to get implanted. So in this era, the genetic diagnosis is very much effective. It can identify the cause properly. It can communicate directly to the patient and families to the condition-specific resources and supports. Like in my clinic, I provide the patient, I try to make them understand about the cause, about the available treatment possibilities and everything. And I also provide them the literature support. And there are some different groups are there in internet where the same kind of people who are suffering from same type of neurodevelopmental disorders, they are having a group, they can interact with each other. So these things will be possible actually. And with an etiologic diagnosis in hand, families may be more empowered to avoid therapeutic intervention. Like in autism, ASD, in some places in the world, they are practicing chelation therapy. Chelation therapy is nothing, it's a process of eliminating harmful minerals such as mercury from the body. If we can identify the cause, if we can identify that the cause is the genetic, this particular gene is not functioning properly because of which the disorder is happening, then this chelation therapy, this kind of potential harmful therapies, we can avoid all this. And it can afford patient and their caregivers the ability to identify, treat, and prevent the medical comorbidities as well. Like in a recent case in my clinic, I will describe that case in detail, that along with the psychiatric comorbidities, psychiatric problems, the patient may develop movement disorder as well. The genetic cause which was identified for him, it also indicates that in future, what type of problem he or she may develop, and according to that, we can take preventive measures for that. Allows us to define recurrence risk and counseling for the family, inform the reproductive decision making. So it helps us to reach the proper diagnosis, the proper genetic pathway which is defective, like in ADHD, the dopaminergic pathway or the serotonergic pathway or the norepinephrine, which pathway it is creating problem. Like in epilepsy, whether the SLC2A1, that is, there lies the problem, or it is in some other gene. If SLC2A1, then the antipsychotic drug will not affect properly. Then we need to follow the ketogenic diet. So all these therapies, all this management will be possible if we can identify the genetic reason properly. So here comes the next hypothesis, which developed in 2018-19. I have found that reverse phenotyping. Reverse phenotyping is that genotype first approach. That is the reverse phenotyping approach in case of neurodevelopmental disorder. Just a minute, I'll have some water. And that is the genotype first approach. This approach enables stratification of patients according to genetic markers, but not according to phenotypes. Normally, what happens? Normally, first, we try to classify, we try to diagnose the patient according to their phenotypic features. Then we go on some biochemical parameters and all. If after all the diagnosis is not made proper, the patient is not responding well to the treatment, then at last we arrive to genetic testing. Because it is something very difficult which people don't understand and all. No problem, you just include a geneticist, maybe a clinical geneticist, maybe a genetic counselor who is expert in this field. You just include a genetic counselor in that management part, what sir said earlier, that the therapist, neurologist, pediatrician, along with all of them, include a geneticist. And he or she may communicate the problem, can direct which test is necessary, and can identify the reason perfectly. The concept arose from the observation that similar phenotypes appears when specific genes are disrupted. We have seen the specific whenever the specific gene is disrupted, like the serotonin transporter is disrupted, then similar type of phenotype has been observed in ASD as well as in ADHD. So go from gene, not from the phenotypes. Such a system can coexist alongside the conventional diagnostic system. For example, there was a study which included that MBD5. MBD5 is methyl binding domain 5 protein. Dose responsive expression of this protein express some disorder which described as MBD5 associated neurodevelopmental disorder, MAND. It's a condition that affects neurological and physical development. Actually, it was a study including all the ASD patients, and the phenotypes expressed by this group of patients was like this in brief: MBD5 associated neurodevelopmental disorder. This is a 2Q20. The phenotypes actually included some sleep disturbances, stereotypic repetitive behavior, short attention span. This may be overlapping with so many neurodevelopmental disorder: motor delay, speech impairment, seizures, ASD, and some people have also described this as pseudo-Angelman disorder. But when the investigation of its genetic reasons they have found that MBD5 protein that is mainly affected in these patients associated. So they have subclassified is at MBD5 associated neurodevelopmental disorder, that is MAND. So in many neurodevelopmental disorder, this has happened that initially we have classified it, they have classified it as ASD, as ID, intellectual disability, at speech delay, as generalized developmental disorder. And then by genetic investigation, they have found the proper reason, the proper biological pathway where the defect is happening. And if the proper treatment is only possible if we can found the proper biological, the exact biological pathway where the problem is happening. So accordingly, the field of biological psychiatry, you may need to change the way in which studies are conducted and reported. So the reverse genotyping concept involves initial genotyping, then followed by exhaustive phenotyping on the basis of the genotype information. So there are few studies based on this reverse phenotyping. One study was a vast one that involved 38,779 individuals, and they have found that within that much individuals, they are suffering from different neuropsychiatric disorders, and they have reported that 6 CNVs, these 6 CNVs they have found commonly in individuals and group of CNVs, and that in SCZ is schizophrenia patients, schizophrenia susceptibility loci present in 1113 individuals. So from this observation, that is the pleiotropic effect. Pleiotropic effect is what? The defect in single gene that is affecting various phenotypes. So here only 6 CNVs they have identified. Those are present along with all those SCZ 1116 SCZ cases. So that is indicating towards a common biological pathway which is causing the schizophrenia among all those patients. In another study was there by Gode et al. They have done a detailed clinical evaluation of 2 families referred for global developmental delay and learning disability, and where they have found that previously it was reported that a missense variant of RABEL6, RABEL6 is a RAS superfamily GTPase protein, RABEL6, it is the underlying cause. It used to be thought in that way. RABEL6 is involved in the causative features of this developmental delay and learning disability. But genetic investigation, after doing that genetic investigation, they have found that the condition is because of a homozygous INPP5B mutation, inositol polyphosphate 5-phosphatase AE. That mutation is causing the problem in those 2 families. And a reason for non-inherited ASD, that is autism spectrum disorder, schizophrenia, global developmental disorder, found to be in most of the cases de novo, that is new variations in most of the cases by a genome-wide association study was reported by Zhu et al. In 2008. And so to date, till to date, there are more than 900 genes responsible for X-linked, autosomal dominant, or autosomal recessive neurodevelopmental disorders. And here in that figure, you can see the mutation load is increasing, so the phenotypical complexity increasing, and gene vulnerability is also increasing. And so now coming to common molecular diagnosis, which are in practice nowadays in neurodevelopmental disorder. In this aspect, first, we need to talk about Fragile X. Actually, the Fragile X was reported long ago in 1970. And after 1990 only, we are being able to identify the proper number of CGG repeats, a trinucleotide repeat disorder. And when the repeat is less than 45 in count, then we consider the protein is functioning as normal. And if it is intermediate, 45 to 54, and full mutation is greater than 200. The most important thing why we need to identify and the number of repeat is actually if in one generation it is intermediate, it is increasing. We call it in genetics as incidence, we call it. So in this generation, it is 45 to 54. It may increase in the next generation. So we need to be concerned about that whenever that early detection and early take care is possible, if we can identify the number of repeats in parental generation also. And Duchenne's muscular dystrophy and Becker's muscular dystrophy of dystrophin gene, we can identify their problem. The deletion and duplication identification in all the 79 is a huge protein dystrophin. 79 exon is possible by using that MLPA, multiplex ligation dependent probe amplification. And that is a cost-effective one test also. It is not, don't cost that much. Next, I'm coming to CMA. CMA is the fast type chromosomal microarray. Fast type of test we use for diagnosis in patients for developmental delay, intellectual disability, autism spectrum disorder, and multiple congenital anomalies like in congenital heart diseases and all. The first line of genetic investigation is chromosomal microarray, because we can identify, and if the case is de novo also, then also we'll first suggest for CMA. CMA, what is this chromosomal microarray? Here I have just tried to put a small figure to make it a little easier to understand the technique. Here, actually, what we do, that we spot that green one is from the patient sample and the red one is the reference. That's from a normal one where no deletion or duplication is present. So now mix and hybridize in a plate. And there, if the amount is equal, 2 copies of patient's gene and 2 copies of control, that equal is present in equal number, that yellow color will develop. So green and red ratio is 1:1. If in patient there is a duplication of gene, so there will be 3 copies of gene, green will be more, red will be less. Green is 1.5 and red is 1. So the signal will be green. And red signal, that means a deletion of gene. So in patient copy, the green is less, and control, the red is in 2 copies. So 0.5:1, the color is developed as red. Here you can see in the graph that here is a duplication, that 3 copies, so extra copy. So the green is in the upper part, that graph, the small peak of green in the upper part, upper side of that line. And here in the lower side of the line, there is a red one, red peak is there. So there is a less number of copy in the patient sample. In that way, by the signal intensities, we can identify whether there is a duplication, whether there is a deletion, copy number variation is there or not. We can identify and we can report. So, and in these cases, you will find in the report, we use that pathogenic, likely pathogenic, uncertain significance, variance of uncertain significance, VUS, likely benign and benign. So in pathogenic, actually the CNVs which are associated already, reported to be associated with diseases, already established research reports are there. If it is, then the report is coming as that variation is a pathogenic one, like 22q11.2 deletion syndrome or 17p 11.2 recurrent microdeletion that causes Smith-Magenis syndrome, like these things which are already established. We call it as a pathogenic one that is present within the patient or not. But in some time we found that some deletion and duplication, some CNVs that we have identified in the patient sample, but that may be causing some problem associated with disease, but where additional evidence could further clarify. Here, actually, the clinical correlation of the clinical phenotype with the identified variation is actually help in diagnosis. And there are some of uncertain significance that do not have enough information to determine if they are pathogenic or benign. And likely benign are those that are considerable evidence to suggest that they are not associated with disease, but where additional evidence could further clarify this. And we call it as benign. that in normal population, there are different databases that 1000 AD is there, CleanVav is there, where we can find that whether any variation is already through the worldwide population, whether any variation is reported to be in CleanVav, is reported to be associated with any disease or not, any CNVs, or in 1000 AD in different population, we can find the various CNVs frequency. If it is present in a high frequency in normal population, normal individuals, then we will consider that CNV as a benign one. Now, the success rate of chromosomal microarray in identify the perfect cause of a neurodevelopmental disorder is reported to be around 15.7%, which is quite high. And now coming to the next generation sequencing basing test, which are being used nowadays. We can use a selected gene panel, which we call as clinical exome sequencing. Selected gene panels, which are actually for neurodevelopmental disorder, we can select a perfect gene panels are being offered by different companies. We can check that. And for like in Rett syndrome, MECP2 is there. Like in epilepsy, SLC2A1, SYNGAP1 is there. CFT is there for cystic fibrosis. That perfect few genes which are already established and being reported by different research finding. There are established findings are there, and based on those findings, there are a gene panel for a particular suspected disorder, and we will order that perfect one. Okay, do for ASD only. ASD, there are maybe 20, 25 or 30 genes will be there, which will be investigated, whether any variations are present within all those genes or not. The next are whole exome sequencing. Whole exome sequencing, actually the coding genes only, which are coding for different proteins, and the clinically most relevant one. Here it is most important to provide the proper phenotyping details, the proper family history and everything we should provide to the genetic analyst who is doing the genetic analysis, the bioinformatic analysis. After doing that next generation sequencing, they will do the searching accordingly based on the family history and based on the phenotypical and clinical data. And then the diagnostic yield of whole exome sequencing is reported to be 31 to 36%, which is a very high one. Whole exome sequencing can identify, in case of neurodevelopmental disorder, a lot of novel variants, different CNVs, and all. Next, there are another two types are there. Whole genome sequencing, which covers up to 95% of the human genome. It doing sequencing for both exoning and non-coding regions, like the promoter region. There are some regulatory region in the promoter enhancer, variants regulating the mRNA translation and stability of mRNA, synonymous mutation, all will be investigated by whole genome sequencing. And RNA sequencing is also there. There may be some problem which are in gene level. These variations are creating problem by after the transcription, in the post-transcriptional level, the problem is happening. Then we can investigate through RNA sequencing. So the recommended guideline for ASD and different disabilities by American Academy of Child and Adolescent Psychiatry is like as follows. First, to do CMA in all individuals with intellectual disability, global developmental disorder, and ASD. FMR1 repeat analysis in males and females with intellectual disability or a family history of intellectual disability. Depending on history of the physical examination, then consider the P10 testing, depending on the head circumference. MECP2 testing for Rett syndrome in females with severe intellectual disability. Karyotype, if a chromosomal syndrome is suspected, if any syndrome is suspected, then karyotyping should be there. And if other investigations do not provide anesthesiology and there are unresolved clinical findings, then consider whole exome sequencing and mitochondrial DNA testing, obviously. And I think in most of the cases where no clue is there, we are not being able to find the proper reason there, whole exome sequencing, that will do. along with the mitochondrial DNA testing, we will be able to find the proper exact reason. So here in the last part of my discussion, I'm just discussing 3 case studies. There are a lot of cases which are very interesting. If in future, if I can find some time, I will discuss a few more. Now I'm just discussing 3 of them. The case study 1, a boy was born from a non-consanguineous marriage and present with clinical indication of speech delay, abnormal social behavior, aggressive behavior developed, and severe anger outburst. His psychological assessment revealed mild autism, and then prescribed with antipsychotic drugs. But the treatment did not have enough response. Actually, the symptoms, anger outburst, everything got worsened day by day. So for better understanding what they have done, they've come to me for genetic counseling. And then we have ordered for first for chromosomal microarray, but nothing was revealed. Then not going to the clinical exome, because if we order for clinical exome, then I had to order for a specific gene panel for ASD, but I didn't want to that. I want to investigate it properly because no serious history was available and anything. So I ordered for a whole exome sequencing. And there's surprisingly what we have found that that whole exome sequencing reveals 2 mutations in MTHFR, methyl tetrahydrofolate reductase, and MTRR. These 2 genes we have found problem which never we have thought of, and the clinical correlation with the high level of homocysteine, high level of vitamin B12, vitamin B6, where a significantly reduced level of cysteine have correlated this biochemical parameters along with the genetic finding, and based on this analysis, it has predicted that the boy is suffering from homocystinuria due to the mutation of MTHFR and MTRR genes, and now he is under proper treatment and he is responding very well to the treatment. Here you can see the game changing is the whole exome sequencing. It was thought that it is mild autism, but after that whole exome sequencing, the diagnosis changed to homocystinuria, and now he is responding very well to the treatment. Now coming to another case study, as a non-consanguineous couple came for genetic counseling to me as they were planning for their first issue. They wanted to have their first issue, and they came for that. The husband also came to me. He was presented with clinical. They told me that doctor identified her husband to have first. One told them that he is suffering from schizophrenia, and another one told them that he is suffering from bipolar disorder, maybe. But I was observing that he was having continuous movement of his cervical region, one hand, mandibular region. And then I asked about that. Then they told me, no, this movement problem was initially was not there. But after starting of the treatment, it is happening. I didn't tell them anything, but I suggested for a whole exome sequencing, and which revealed a mutation in BPS16 gene at intron 12 3' splice site. And it is involved with the dystonia 30. Here in dystonia 30, the psychiatric problem may happen, which he is suffering, and the movement disorder, which already have started in him. So I have made the diagnosis, diagnostic detail of which can be happen in case BPS16 is defective. Actually, in this picture, you can see this is a homotypic fusion and protein shorting complex, Hope's complex, and Hope's complex associated neurodevelopmental disorder, Hope's, and they classify it like that. And here he is having problem in the structural breach necessary for the fusion of late endosomes and autophagosomes with the lysosome when the late endosome and autophagosome is fusing with the lysosome, there they need this Hobbs complex. In the Hobbs complex, the PPS16 is a core part of this Hobbs complex. So here also, this genetic testing has played a very informative and very important part in the diagnosis. And now I'm coming to the case study 3. It's a rare disorder. It's a baby. It was a baby girl, nearly 1 year of age. And she was presented with clinical indications of protruding tongue, by which the doctor diagnosed it maybe of Down syndrome. But they have lost their first baby. And at that time also, doctor told them the baby was Down syndrome. And after 1 month of being in the NICU, that baby expired, and it was their second baby. And she was also having protruding tongue, acute gastroenteritis, dehydration with secondary lactose intolerance, watery stool, fever, vomiting, developmental delay, dysmorphic faces, light-colored eyes, and all. And then again, I need to order for, suggest them for whole exome sequencing. Here, it was diagnosed as POMC. POMC deficiency is a very, very rare disorder. She is having a homozygous 2 base pair deletion in the exon 3 of the POMC gene, pre-opiomelanocorticoid gene there, that results from a frame shift and a premature truncation of the protein, 17 amino acid downstream to the codon 101. So POMC is the pre-opiomelanocortin. It's a precursor polypeptide that can be cleaved to yield several important hormones: ACTH, alpha MSH, beta MSH, melanocortin, endorphin. So all these hormones are being synthesized from this precursor polypeptide. And here that girl is having problem here. Actually, here that picture I am just given from their prescription only, which I have drawn in their prescription. Here, the red part, that is glycine to frame shift 101, is termination codon is there. So the patient is only having 118 amino acids are being coded. The rest of the thing, that is the ACTH, that MSH, that endorphin, these are not being produced within that girl. So glucocorticoid replacement and adrenal insufficiency treatment should start immediately. So after that diagnosis and genetic counseling, after understanding the whole thing, the next day morning, they rush to the pediatric endocrinologist, and she is under treatment, having proper treatment, I think. And if she survives up to 6 years, there are perfect therapy for that. There are recommendations for perfect therapy. All the research insights, finding the details and everything, I have also provided them for their future reference, and they have shown all these things to their pediatrician, and hope for the better thing that she is receiving the proper treatment and everything after the proper diagnosis also, and which is only possible because of the genetic diagnosis. So it is in your hand. Reach the correct diagnosis, option for proper genetic diagnosis, incorporate a geneticist in the clinic, a pediatrician, neurologist, all the therapists. Along with that, include a geneticist in your panel. Identify the reason for proper management. If we can identify the proper reason, if we can reach the proper reason only, then we can identify the proper biological pathway which is being malfunctioning within that disease, because that different genes are responsible, different interactions are there, multifactorial origin of disease, and again that comorbidities. So to reach the proper diagnosis, genetic diagnosis can help us only. So it is in your hand, it is your choice whether you will opt for it or not. I will request all of you to consider the genetic diagnosis. It will help, it can help the proper treatment. So thanks to all of you. And in case you have any question, you have any queries, not only this time, in future also, you can contact me, you can ask me anytime. Thank you.
Thank you very much.